Yeah, sure.
Yes. So today we'll be discussing normal knee kinematics and gait deviations.
Someone has
So
two devices logged in, so echo आ रहा है.
so today we'll be discussing normal knee kinematics and gait deviations in knee. So just to recap of what have we learned previously. So we know that the events that occur from one foot contact to the other is consist of a gait cycle. It is divided, one gait cycle is divided into stance phase and swing phase. The first part is when the foot is in contact and foot is in contact, which is the stance phase, and the next is when the limb is moving, which is the swing phase. So we should, in order for us to understand, we have just put both uh, basically both lower limbs which coincide is the double supported period. And this double supported period, there is a moment when the contralateral limb also goes into swing, which is called a single support period. And again, there is a terminal double support period. So the stance phase is again divided into mid stance and terminal stance. So the entire gait cycle consists of initial contact, loading response, mid stance, terminal stance, pre-swing, initial swing, mid swing, and terminal swing. So the swing and stance phases have different purposes. The purpose of swing phase is to advance the limb, and the purpose of stance phase is to advance the body over a planted foot. So the stance phase is all to do advancing the body over the stance phase limb, and the swing phase is to advance the leg. As we know that there are different tasks which are assigned. So weight acceptance is basically the task in initial contact and loading response, and single in mid stance and terminal stance, it is single leg limb support. And swing limb advancement is there in pre-swing, initial swing, mid swing, and terminal swing. So coming to the basic functions. So during walking, the body is functionally divided itself into two units, which is the passenger and the locomotor. Normal gate mechanics are so efficient that the demands of the passenger units are reduced to a minimum, making it virtually a passive entity. Uh, as we can see, the normally the center of gravity in the second image, we can see that the center of gravity just lies anterior to the 10th thoracic vertebrae. And in the third image, we can see that the locomotor system, which includes the pelvis and the both lower extremities. So as the locomotor unit carries the body to its desired location, it accomplishes four different functions, which is a propulsive force is generated, upright stability is maintained despite an ever-changing posture, and the shock of the floor impact at the onset of each stride is minimized. And energy is conserved by these functions, which is being performed in a manner that reduces the amount of muscular effort required. So the accomplishment of these functions depends on the distinct motion patterns of each different joints. Uh, Prerequisites of gait, which are the 5 points, which is foot pre-positioning, adequate step length, clearance in swing, stability in stance, and energy conservation. So these five are very important for a gait to be normal. If any of these five aspects are affected by the disease or any injury, then obviously we will have an adverse impact on the overall gait pattern. So coming to role of knee in gait. So role is to transfer load between thigh and leg while maintaining the alignment, coordinates with hip and ankle for energy efficient locomotion. So the functions include shock absorption during loading response, stability in stance phase, limb advancement during swing phase. So coming to knee motion. So knee movement occurs in three planes. The sagittal plane, which is flexion extension, is most easily observed, uh, which is the primary contributor to forward progression in stance and limb advancement in swing. Coronal plane movements help to maintain a vertical balance, and transverse rotation accommodates alignment with changes as per body moves over the stance limb. So in sagittal plane, as we can see in this graph, in initial contact, knee is flexed up to 5 degree. Then in loading response, rapid flexion occurs up to 18 degrees when the knee is under maximum load. In mid stance, again, the knee gradually extends to a minimal of 3 degree of flexion. And in late stance, the second wave of flexion begins, where knees again flexed at the end of single limb support. In pre-swing, again, there is rapid flexion, which resumes to almost a 40 degree, and maximum flexion is reached at the initial swing and the mid swing phase. Then again, this is gradually, then there is extension in the terminal swing phase, which is seen. So a flexion peaks of around 60 degree in initial swing is important, which we'll be discussing in the later slides. So just a brief on vector pattern and physiological torque. So during stance, the relationship of the body weight vector to the knee creates four different torque patterns. The sequence is extension, which you can see in the first image, then flexion, and then again in extension in the mid stance, and then in the throughout the swing phase, again there is flexion. So the initial impulse of striking the ground, striking the foot on the ground creates a vertical vector. Since the point of the floor contact is anterior to the knee, there is an extensor torque which is created, which causes the knee to be in extension. As the body weight drops onto the limb during the loading response, this vector rapidly aligns itself with the source of the ground reaction force. This moves the weight line back towards the body center, which creates in loading response. That's why the ground reaction force grows posterior to the knee, which causes slight flexion in the knee. So this is a flexor moment which is created. Then with the onset of start of stance limb or the single limb support, the relationship between the body mass and the supporting limb begins to change. This reverses the direction of vector, and it again comes just anterior to the knee, which causes the knee to be in extension in mid stance and in terminal stance. Then again, when the flexors start acting, then in initial swing and mid swing, the body vector starts going posterior to the knee joint, which itself causes the knee to be in flexion. So these are the vector patterns which will be discussing in the later slide. So just a general clue, what muscles are acting on the knee. So only muscles which are acting on knee are the four vastus, the latalis, VMO, vastus medialis, and vastus intermedius. Popliteus, short head of biceps femoris. They purely have knee control. Whereas muscles, there are some muscles which control both hip and knee, which include rectus femoris, hamstrings, which include semimembranous, semitendinous, and long head of biceps femoris, gracilis, and sartorius. They control both hip and knee. Whereas knee and ankle is gastrocnemius and soleus. So knee flexion plus ankle plantar flexion is controlled by these two. So there are different muscles which are activated in different phases of gait, and they have different roles in each of the phases. So in terminal swing, we will again be discussing in later set, but just a short overview. In terminal swing, the vasta and the hamstrings are affected. They basically they decelerate the ring and they prepare for contact, initial contact. Whereas in loading response, the vasta and the gluteus maximus are activated. They control flexion and stabilize the knee. In mid stance, there is minimal activity and passive stability is achieved. In terminal stance, gastrocnemius and controlled tibial motion is achieved. Whereas in pre-swing, rectus femoris, it initiates limb advancement. And in mid-swing, the biceps femoris, short head of biceps femoris causes flexion of the knee for clearance. So coming to functional interpretation, the knee has three functional obligations during walking. Two occur during stance, which is shock absorption as the limb is loaded, and extensor stability for secure weight bearing. And in swing, the knee must rapidly flex for limb advancement. The relationship between the motion and the muscle actions relate to these demands. So coming to each individual phases, we'll be starting with the terminal swing. So I'll be saying some parts where Mohit was describing what happens in ankle, and then we'll be going to the knee. So to understand it clearly. So previously, like we discussed in ankle, the motion is ankle is at neutral, and the function is to prepare for the initial contact. So during terminal swing, the knee must reverse its earlier previously flexion movement and cause it to be in full extension. So this requires active quadriceps contraction, particularly from the four vasti. Uh, to lift the tibia and the foot while the femur is positioned of about 30-degree in flexion. So previously it was stated that only the eccentric contraction of hamstring is causing this movement to happen. But later on with EMG studies, it is suggested that active vasta engagement is essential due to limited available time in the gait cycle. And the rectus femoris is not recruited in this because additional hip flexion is undesirable at this stage. And hamstring, like we discussed, it acts antagonistically or eccentrically to prevent excessive or abrupt knee extension, ensuring controlled limb preparation for the initial contact. Uh, so, like we discussed previously, the hip is flexing, and the hamstring suddenly stops the hip flexion and then extends the knee, which is eccentrically causing it. Then coming to the next phase, which is the initial contact. So we know in ankle at initial contact, the ankle is positioned neutral up to 90-degree to allow an effective heel rocker, which is essential for forward progression and shock absorption during this loading response. Here we know that the ground reaction force is posterior to the ankle joint, preparing the limb for controlled tibial progression. This neutral ankle position ensures the forefoot is optimally elevated so that the heel can support the body momentarily. While meanwhile, the pre-tibial muscles, the dorsiflexors, hold the foot in this posture. If there is any insufficient control, where there is 3 to 5 degree of plantar flexion, it reduces the effectiveness of this heel rocker. Coming to knee, at in knee joint, at initial contact, the knee is positioned in stable extension. The range is from -2 degree to 5 degree of flexion. The stability is basically coming from two mechanisms. One is the passive alignment stability, which is by the ground reaction force, as we can see in the image above. So the ground reaction force at ankle is posterior to the ankle, and in knee, it is anterior to the knee. So which creates an extensor torque, like we discussed in at the knee joint, causing it to be in extension during heel strike. And then the other mechanism is the active muscular control. So the vasti remain active from their terminal swing role, like we discussed, contributing to this controlled knee extension. One more way is the gluteus maximus iliotibial band complex. This is also activated in the late swing, which provides an additional support. So this is about initial contact. Now coming to loading response. So again, going back to ankle, this is where there is first arc of plantar flexion, which was discussed. At initial loading, this ground reaction force is vertical, giving stability, but not forward progression. Because the ground reaction force lies posterior to the ankle, a plantar flexion torque is created, which is the first arc of plantar flexion. The pre-tibial muscles here eccentrically decelerate this plantar flexion. So the purpose of this, the heel rocker, is basically to draw the tibia forward, like we can see in this image. And this is basically the heel rocker. So this is what is happening in the ankle. Now coming to knee, knee response. Here, the heel rocker action rolls the tibia forward. As you can see, the tibia is going forward, which creates a flexor moment. This movement threatens knee stability, but controlled flexion provides shock absorption. So the vasti contract eccentrically again. So the opposite muscle or the antagonist muscle is always contracting eccentrically to control any excessive movement. So here the vasti are the one which are contracting eccentrically to restrain the knee flexion. And a limit is up to 15 to 18 degrees. Additional shock absorption in a coronal plane is also given by there is also an adductor torque which is happening. So the long head of biceps femoris, the gluteus maximus tension, and the iliotibial band tension, they provide a lateral stabilizing force during this phase. So they give a coronal stability as well. Now coming to mid stance. So in mid stance, previously discussed like in ankle, there's this first arc of dorsiflexion which is happening. So during mid stance, the ankle acts as an ankle rocker, allowing forward progression of the body. As the body momentum and the forward fall advances, the body vector across the foot and increasing dorsiflexion torque rolls the tibia forward. So here soleus is very important as the soleus is dominant as well compared to gastrocnemius. So while soleus directly links, it links tibia and calcaneus a stronger and its largest plantar. But meanwhile, gastrocnemius activates later in this stage, as also it originates from femur and not the tibia. So it activates later in the stance phase. So this is what is happening in the ankle rocker. Meanwhile, in knee, as you can see in early mid stance, the full body weight is accepted and the knee initially flexes up to 5 degree, which the vasti control eccentrically by contract. And there is which the vasti control by increasing the activity. Uh, Tibia becomes vertical and the ground reaction force aligns with the knee while itself causing it to be extension. The soleus is actively restraining the tibial progression here. So that is one of the other reasons why it is keeping the knee in extension. Meanwhile, in mid-stance knee stability, as the tibia dorsiflexes and the knee extends, the body mass moves forward, shifting the vector closest to the knee axis. This provides a small passive extension again, stabilizing the knee without any vasti activity. So the knee stability is maintained by the body alignment itself, the ground reaction force, and the reduced muscular demand. And like we discussed in coronal plane as well, in the gluteus maximus and the iliotibial band complex, this causes a lateral shift of the body of up to 2 centimeters and the foot up to 4 centimeters. So this lateral stabilizing force is also very important during a normal gait cycle. So this is in mid stance. Now coming to terminal stance. Going back again to ankle, we know at as the mid stance ends, the body vector is shifting onto the forefoot. So previously it was heel, then ankle, and now it is shifting to the forefoot. And the soleus and the gastrocnemius, they lock the ankle. So when the tibia continues advancing, the heel rises, as you can see in the image below, which creates a forefoot rocker. The full forefoot length becomes the dorsiflexion moment arm, generating a maximal dorsiflexion torque. This is what is happening in the ankle. Now coming to knee, there are three factors. The motion here is completion of the knee extension, and the function is stable weight bearing with further stride length. This is achieved by three mechanisms. So these three factors keep the knee extended and stable. One is strong ankle plantar flexion, which stabilizes the tibia as the femur advances. So the soleus and the gastrocnemius are stabilizing the tibia, while meanwhile the femur is advancing, which keeps the knee in extension. And continued swing limb momentum. So the contralateral limb is in the swing phase, aiding progression to the decreasing knee flexion demand on the ipsilateral limb. Forefoot rocker, this allows the body vector to roll forward while staying slightly anterior to the knee joint, creating a passive knee extension movement. Meanwhile, here the tensor fascial lata also limits hip hyperextension and the tensions in the iliotibial band, indirectly causing a knee extensor support. So preventing hyperextension is very important in these phases. So two posterior muscles, like we know, are the popliteus and the gastrocnemius. So these are very effective, and out of which popliteus is more effective as it is close to the knee joint and it is in the deeper plane. So transition of this phase from terminal stance to pre-swing. Here these hyperextension forces again, the hyperextension previously which was preventing, then suddenly a flexion torque is created. So as the body vector is moving far forward beyond the metatarsal heads, the tibial stability is lost. So the posterior muscles that previously prevented this hyperextension now initiate a knee flexion, which is basically unlocking the knee, which is the function of popliteus. So this initial flexion is also very important to create a larger flexion arc needed at the initial swing phase. This happens in a very short time window as well. Now coming to pre-swing. So again going back to ankle, here the in pre-swing begins when the opposite foot is in contact. So there is rapid transfer of body weight from to the contralateral limb. Because the limb is unloading, the soleus and the gastrocnemius rapidly reduce the activity, because of which the ankle then rapidly plantar flexes to around 20 degree. This is the second arc of plantar flexion. So, which helps to accelerate forward advancement of the tibia and contributes to early swing initiation. So we know that the floor contact here is only maintained by the metatarsophalangeal joints, allowing the foot to plantar flex freely. This plantar flexion paired with the residual plantar flexion tone. So the gastrosoleus and the gastrocnemius and the soleus, they basically are causing the plantar flexion, and the tone which is still present in them causes the nudge of tibia to go forward, producing a rapid knee flexion near the end of pre-swing phase. Meanwhile, the anterior muscles, which are the tibialis anterior and the toe extensor, they decelerate foot drop. So they have to prevent foot to drag. So here in knee flexion, it is basically three mechanisms which is causing the knee flexion. One is loss of midfoot stability, where we discussed the center of pressure is now moved distally to the metatarsophalangeal joint, and the midfoot loses ground support, which is causing the tibia to free fall forward, which is initiating the knee flexion. And the second one was the residual plantar flexion tension by the gastrocnemius and the soleus, which were previously very active. This causes the nudge in tibia to enhance the passive knee flexion. And the another is direct contraction of popliteus and the gastrocnemius muscle, which is again causing the knee flexion. So these, when the contraction of gastrocnemius and popliteus muscle happen, a total of around 40 degree of passive knee flexion is achieved. This is very critical for toe clearance in this initial swing phase. Meanwhile, the antagonist muscle, which is the rectus femoris, if knee flexion accelerates too fast for a degree of unload, rectus femoris is activated. So antagonist muscle is being excessive movement which is happening in the agonist muscle. Of activity limits any hip hyperextension as its attachment as well. Then coming to pre-swing phase. Sorry, pre-swing you're done. Coming in initial swing, again, we're discussing of ankle first. So at toe off, the ankle is in 20 degree of plantar flexion. This does not initially hinder forward swing because the limb is still trailing. So to clear the floor during mid swing, ankle motion must reverse to dorsiflexion, which is the second arc of dorsiflexion. Here, this is given by the pretibial muscles, which is the tibialis anterior and the toe extensors. This is what is happening in the ankle. In knee, the here the knee function is basically to shorten the limb to allow clearance despite its trailing posture. At the end, we discussed in at the end of pre-swing, the limb is already trailing behind and the ankle is in equinus. This makes the functional limb length longer, which is the hip to floor distance. Therefore, ankle dorsiflexion alone will be insufficient to clear this swinging limb. That's why knee flexion up to 60 degrees is essential to lift the toe and prevent floor contact. The mechanisms by which 60-degree knee flexion is achieved is by three types. One is that the pre-swing initial knee flexion, like we discussed, which is up to 40 degree. This is very important as this sets the limb in a correct position before the swing phase even begins. The second is the momentum from the rapid hip flexion. So the hip flexors, the iliopsoas, they themselves start flexing, and the tibia inertia lags behind, which causes the knee flex passively. And the another one is the short head of biceps, which is the key active knee flexors. This is the only hamstrings which is mainly active of the knee. Rest every all the hamstrings are coming from the hip. So activation of those will cause hip extension, and we don't want it in the initial swing phase. We want hip flexion to happen. Meanwhile, the other accessory muscles like sartorius and brachialis, they also assist with simultaneous hip and knee flexion. So this is the initial swing phase. Now coming to mid swing, again going back to ankle, here as the tibia reaches a vertical position, the weight of the foot causes an increased downward torque, demanding a strong dorsiflexor effort. So the pretibial muscles, the tibialis anterior and the extensor hallucis longus, they keep the foot in dorsiflexion. Meanwhile, in knee, there is passive knee, which is how is this passive knee extension happening? Oh, swinging foot passes anterior to the hip, the risk of toe drag ends. So the knee no longer needs a deep flexion. So the normal extension begins. This is achieved by no active contraction of quadriceps. Relaxation of knee flexors is happening, because of which gravity is pulling the tibia downwards, and the ongoing hip flexion momentum itself causes the tibia inertia, which causes it to be in extension. So this is a passive movement which is happening. Coming to terminal swing, like we discussed previously, the knee must reverse its initial flexion arc and return to full extension. This is done both by the quadriceps contraction, like we discussed, and eccentric contraction of the hamstring, which is antagonistic active. So this is what is happening in the normal phases in the knee. Now coming to abnormal deviations. So abnormal deviations is the most common types of knee dysfunction, occur mainly in sagittal pain. In any inappropriate arcs of motion result in either excessive or inadequate flexion or extension. So less frequently are deviations also in coronal plane, which we know are the varus and valgus. And sometimes there is excessive transverse plane rotation within the knee is reported, but these findings vary with the method of the measurement. So sagittal plane deviations, it is divided into flexion and extension. So inadequate flexion defines the failure to accomplish normal amount of flexion which is required, with the result being either limited or absent motion altogether, whereas excessive flexion is more than the normal rate. So this and inadequate extension relates to persistent flexion, like knee contractures. We'll be discussing the causes later. And excessive extension indicates the motion beyond the neutral. So the timing of these gait deviation relates to normal incidence of the basic motion. So just an overview again of what is happening when there is inadequate knee flexion. Now we know that knee flexion is required during 4 phases of gait: the loading response, pre-swing, initial swing, and the mid-swing. So all these phases are affected. So we know in loading response, the normal role of knee is shock absorption via 15 to 20 degree of flexion. So what happens when there is inadequate knee flexion? One is, it is, since it's a rigid limb, there is reduced shock absorption, and the body weight is transmitted directly from femur and tibia without any muscular cushioning. Uh, uh, in uh, in pre-swing, the normal role of knee is up to 40 degree of knee flexion to prepare the limb for initial swing. The effect of inadequate knee flexion here, toe off becomes difficult. So the transition from between stance to swing becomes inefficient, and the patient must use excessive hip flexors for direct knee flexor effect. The key point is, in pre-swing is still a weight-bearing phase. So no compensations are available until the limb begins forward swing. And in initial swing, we know the normal rule is 60 degree of knee flexion for toe clearance. So any inadequate flexion here again causes toe drag and inability to advance the limb forward. The limb remains functionally long because the trailing limb is in equinus without knee flexion. So the distance between hip to toe is increased. So that's why it becomes difficult and limb advancement is improper and toe drag is present. Causes include pre in the mid swing phase. The normal function of knee here is to maintain the 25 to 30 degree of flexion until the limb is vertical in mid swing. And the causes effect of this inadequate flexion usually rarely occurs alone in mid swing. It is usually because of either insufficient hip flexion which is occurring or any cause in the initial swing phase. Coming to excessive extension. So there are two terminologies, which is extensor thrust and hyperextension. Extensor thrust is basically a rapid, forceful knee extension movement which is happening. It is caused by an excessive extensor torque or a moment when knee does not have any hyperextension range available. And it's a dynamic or an abrupt action. So knee is driven posteriorly, but it cannot go beyond neutral because the normal anatomy blocks itself, so it represents an extensive force overpowering the knee without any actual recurvatum which is happening. Meanwhile, in hyperextension, which we know as genu recurvatum, here knee moves beyond neutral into backward angulation due to available hyperextension mobility. So these are very small different terminologies, but the basically the uh, functional aspect is extensor thrust is basically an early sign with true hyperextension occurring later as the pathology worsens or the stance demands increases. So now coming to causes of inadequate knee flexion and excessive extension. Mainly they are quadriceps weakness, pain, quadriceps spasticity, any excessive ankle plantar flexion or any hip flexor weakness or any extension contractions. So we'll be discussing this one by one. Uh, Coming first to quadriceps weakness. So I have just mentioned in these subsequent slides normal function of the knee during the gait phases and what is the effect of the pathology like in this thing quadriceps weakness and what are some substituting mechanisms which the body uses to overcome these pathology. So first is terminal swing. So again, going back to the gateway. So once we understand what is happening in each joint, we know what the normal function is. It is easier for us to understand what will happen if there is any pathology like in quadriceps weakness. So in terminal swing, the position of the knee is extension before the weight bearing, before weight bearing or the initial contact happens. So here the normal function is knee extension and the effect of quadriceps weakness will be incomplete extension. So how does the body tries to overcome this? So either by a quick hip flexion, which advances the femur and the tibia altogether, or rapid hip extension. So rapid hip extension, like the gluteus maximus, retracts the femur while the tibia still holds inertia, which causes an extension move. So this is a substitution mechanism which is used. In loading response, we know there is controlled knee flexion which is required. So patient use two key strategies to block this loading response. One is hip retraction again, and another one is premature ankle plantar flexion. In hip retraction, again, like we discussed previously, the gluteus maximus pulls the thigh backward, preventing the knee from bending. And in premature ankle plantar flexion, which is early soleus activity, it blocks the forward tibial progression, which prevents the heel rocker and the knee cannot flex. Meanwhile, the knee stays in extension. So these substitution preserves walking speed and stability. In mid stance and terminal stance, the goal of the knee is to lock, the goal of in mid stance is to lock the knee into a stable position because active control is required here. So knee needs to be stable in mid stance. So if passive hyperextension is available here, the patient uses this stabilizing. With a weak quadriceps, the anterior ground reaction force again becomes your body vector, which is causing the knee to be in hyperextension. Here, sometimes the patient uses anterior trunk lean. So anterior trunk lean is again causing the ground reaction force to be anterior, which causes again an extensor moment at the extensor torque at the knee, causing it to go into hyperextension. So if hyperextension range is absent, then the patient will either use prolonged gluteus maximus activation, So whenever gluteus maximus activation acts through the iliotibial band complex, which gets attached to girdis, this will cause an extension of tibia. But normally this doesn't happen. But if the quadriceps weakness is present, this pathway is activated. And prolonged soleus activation, like we discussed. So soleus is preventing the tibia to move forward, and forward trunk lean, like we discussed, which shifts the GRF to anterior. In pre-swing, the normal function is knee flexion. So the goal is to prepare the limb for the swing, but weakness of the quadriceps obstructs the normal mechanism. So the patient keeps the knee fully extended until the body weight has completely shifted to the opposite leg. So either weak quadriceps and weak plantar flexions substitute. So the substitution pattern here is basically it maintains extension until weight transfer is complete to the opposite leg. So this is an image which explains us that basically in the first image we can see the soleus is preventing the tibia to move forward. So it is basically retracting the tibia, which is again causing knee extension. Here we can see the anterior shift of the ground reaction force, which is causing an extensor moment at the knee, which is again causing the knee to be in hyperextension. Coming to another pathology, just pain. So knee pain because of any intrinsic joint pathology causes avoidance of rapid knee motion. So any pathology, including any arthritis or any other causes, this basically here again in loading response, we want a controlled knee flexion. But because of pain, this flexion is avoided. So the goal is to reduce the shear and compressive forces on a painful knee. So patient avoids knee flexion using some substitution, as in same similar to quadriceps weakness. One is hip retraction by the gluteus maximus or premature ankle plantar flexion by the soleus, which prevents the heel occur. So a reason is flexing the knee, increasing the joint shear forces again, and quadriceps contraction is needed to control this flexion, which increases the compressive force again. So common causes like we know are arthritis or any instability or any multi-ligament injury as well. In pre-swing phase, now the normal function of knee is to initiate this flexion. If because of pain there is limited flexion, again these compensatory mechanisms start occurring. In initial swing, we know that rapid flexion is required for clearance of the toe. So here the goal is to both reduce the pain from rapid flexion acceleration. So a passive range of motion may be normal on examination, but the functional arc is always reduced during the gait. So this gives us the stiff leg gait. So patient will try not to move the knee at all and keep it in the fixed position of the knee. One more pathology is quadriceps spasticity. So quadriceps spasticity is normally triggered by a stretch response to rapid passive knee flexion. So because the loading response and the initial swing both involve a fast knee flexion, they are the phases most vulnerable to quadriceps overactivity. In loading response, mechanism normally is the heel rocker induced deflection, which produces a rapid quadricep stretch. So the vastus respond with excessive activation, blocking this normal knee flexion. The result will be again premature knee extension instead of a normal 15 to 20 degree flexion, which is expected in loading response. A combination of forward trunk, ankle plantar flexion can give a false impression of hyperextension even when true recurvatum isn't present. So these compensatory mechanism causes the knee to be in knee hyperextension, even though when there will be no true recurvatum which is present. Then again, in coming to initial swing, in quadriceps spasticity may involve either rectus femoris, vastus, or vasti. So there are different again patterns of quadriceps overactivity, which is either only in rectus femoris or only in vastus intermedius or in all vasti. So only if rectus femoris is overactive. So rectus femoris will remain overactive intensely for too long, which blocks early swing knee flexion, and it often occurs when gait velocity is too slow eliminating the need for rectus femoris to restrain the knee extension. So because rectus femoris has a primitive hip flexor role as well, so inappropriate activation is common. So here surgical release or transfer of rectus femoris can significantly improve knee flexion. So this different patterns of quadriceps plasticity will we can only see through instrument gait analysis or by dynamic EMGs. One more pattern of quadriceps overactivity is only vastus intermedius activity. So we can see this in dynamic EMG. So the release of only vastus intermedius will help us to um, basically, uh, if only vastus intermedius is overactive, then we can only cause surgical release of that. And and the last one is when all vasti are basically important. When all vasti are active, a major proportion of swing. If vasti also remain active until toe off, this represents an uncorrectable pattern because all these vasti are active. We cannot sacrifice all the quadriceps. So the clinical importance basically remains that quadriceps spasticity will prevent normal knee flexion in loading response, which will cause poor shock absorption. It pre-swing knee flexion, which will again cause poor swing initiation, and inhibit initial swing knee flexion, which will cause toe drag. In another pathology is excessive plantar flexion. So loading here, the in loading response, inhibition of knee flexion is seen. So mechanisms include when the ankle is excessively plantar flexed at initial contact, the tibia cannot progress forward normally. This prevents the normal 15 to 20-degree flexion which is required in loading response. Common causes include any plantar flexion contracture or any soleus spasticity. So the result is the knee remains extended and stiff, and it does not do its normal activity, which is the shock absorption. In mid stance and in terminal stance, development of hyperextension is seen. So when plantar flexion is less severe, hyperextension often appears late in the stance phase. So the tibia cannot follow, which result the femur is advancing over a stationary tibia. The tibia cannot follow it, because of which force causes the knee to be in hyperextension. So the severity of this ankle plantar flexion is also very important for in treatment perspective. Coming to one more pathology, which is hip flexor weakness. So knee flexion during initial swing depends heavily on the momentum which is generated from hip flexion. So when hip flexion is insufficient, the knee cannot achieve this normal 40 to 60 degree of flexion, leading to a delay or reduced swing phase knee flexion. So mechanisms, when there is weak or insufficient hip flexion, it removes the momentum which is normally used by the knee itself. This problem is worsened if pre-swing knee flexion was already inadequate. So in clinical patterns, for example, slow walkers. So if when slow gait, it reduces the natural momentum of the natural momentum of the gait, because of which they require more hip flexor effect to initiate this knee flexion. So without it, knee flexion becomes inadequate. With weak iliopsoas or rectus femoris, the thigh remains vertical rather than advancing forward. So tibia inertia alone is insufficient and the knee stays relatively extended. Compensation here is normally mainly by the short head of biceps. As we know, it's a active knee flexor. So substitution mechanism by short head of biceps actively contracting when there is hip flexor weakness is seen. Then coming to causes of excessive flexion and inadequate extension. So previously we were discussing inadequate flexion and excessive extension. So here inappropriate hamstring activities, knee flexion contractures, soleus weakness, and excessive ankle plantar flexion. Coming to inappropriate hamstring spasticity. So we know that excessive hamstring activity is seen in upper motor neuron lesions like cerebral palsies. So hamstring overactivity can be either premature or prolonged. These errors basically disturb the knee extension in terminal swing and causes increased knee flexion because of the overactivity. So normally hamstring activate only at the terminal swing, like we discussed. With spasticity, this activation begins in other phases of gait cycle as well. Like, for example, in mid swing and terminal swing, there is inadequate knee extension which is achieved. So during mid swing, hip flexion momentum lengthens the hamstring and it stretches, and this stretch triggers premature overactivity. This interrupts the normal passive knee extension that should normally be occurring. In terminal swing, quadriceps attempt active knee extension, but because again of overactivity, they mechanically overpower the quadriceps. The result being incomplete knee extension and poor limb preparation for this initial contact. Coming to loading response, here we see our typical crouch gait, which is seen. So in loading response, we know the normal function is controlled knee flexion. When floor contacts adds to the ongoing hamstring pull, which causes increased knee flexion at weight acceptance. So the stability is preserved only by strong quadriceps activation and stimulation of primitive extensor synergy. So patient may appear crouched or excessive knee flexion is seen during the loading phase. In mid and terminal stance, two possible mechanisms explain why stance phase flexion. One is primitive extensor pattern. So hamstring remain abnormally active as a part of mass extensor synergy and the functional compensation by the forward lean of the trunk. So forward trunk lean is one of the functional substitution mechanism in which the people uh, in hamstring spasticity, which is seen. So here we can see forward trunk lean, the hamstring is spastic, knee is flexed more than normally what it should be doing, and the forward trunk lean is causing basically a support pad. And other causes which is seen is knee flexion contracture. So normally we know a swollen or any stiff knee rests normally in 30-degree of flexion, making 30-degree flexion contracture a very common occurrence. So effects of this 30-degree knee flexion can be seen in it affects all gait phases, because of which all gait phases becomes abnormal, except only initial swing where this 30-degree of flexion is desired. So in terminal swing, again, normal function we know is full extension, and the effect of flexion contracture will be in incomplete extension, and the compensation is stop length, shortened step length, which is seen. In initial contact, we know that normal function is heel strike and extended knee, and the effect of flexion contracture is flexed contact. So partial recovery even to 15-degree contracture is desirable because restoring this passive extension to 15-degree flexion allows loading response and pre-swing phase. So previously in 30-degree flexion contracture, all gait phases will be affected. But if we even surgically, if we even achieve 15-degree of release and we can get it better to at least 15-degree of contracture, other phases like loading response and pre-swing can appear more normal than previously. So functional consequence mainly that even if a knee flexion contracture is reduced from 30 to 15-degree, it creates a major deficit in extension dependent phases and it significantly increases energy cost and quadriceps workload during the gait cycle. Then in soleus weakness. So we know soleus is a major controller of tibial progression during stance. When weak, it fails to restrain the tibia as the body advances, producing a characteristic pattern of persistent knee flexion, which is seen. So, in normal gait, the soleus is eccentrically contracting to restrain the tibia to move forward. With weakness, the tibia falls forward too rapidly. So, the tibia advances faster than the femur, preventing the normal knee extension. So, the effect will be the knee remains in flexion instead of extending through the mid and terminal stance. So here the question arises why quadriceps cannot correct this problem. So if knee is free falling and knee is going into flexion, why can't quadriceps correct the problem? So despite being strong enough, the quadriceps cannot regain the knee extension because tibia one is unstable. So quadriceps pull from the tibia to a collapsing tibia cannot create an effective extension moment, and the quadriceps action worsens this collapse. So when the quadriceps tries to extend the knee, they also pull the body mass forward at the hip. This again shifts the ground reaction force anteriorly, which again causes an increasing external dorsiflexion torque. So the weak soleus cannot resist this, and the tibia collapses even more, and the knee stays flexed. So the outcome will be that the entire limb advances as a unit instead of femur advancing over a stable tibia. In the entire stance phase, we know that the normal function is to keep the knee in stable position. When there is soleus weakness, there is ineffective pull of the quadriceps, and because of which it creates a crouch posture, which causes again reduced step length. Excessive plantar flexion. Ankle plantar flexion increases again the distance between the hip joint to the toe. So this functional length is being increased. When the swing limb must pass the stance limb, this longer functional limb must be compensated. If there is no anatomical shortening, the compensation must occur at knee through increased flexion. In mid-swing phase, the normal function we know is dorsiflexors, which lift the foot for clearance. Because of excessive plantar flexion, the foot drop or toe drag occurs. Here, the compensatory actions will be excessive hip flexion, which causes an apparent knee flexion. In late swing, we want the foot positioned for contact. Because of excessive plantar flexion, the limb again remains long, the compensatory action here which is created is delayed heel strike or forefoot contact. The last phase is the coronal plane deviations, which is both the varus and valgus. So this is in the coronal plane movement. We know that the valgus is basically distal tibia moves laterally, and it creates a knock knee appearance. Common false causes normally we have to rule out is when hip is in internal rotation and knee flexion, whereas in varus, knee flexion and external rotation can be a false cause for this. So this has to be ruled out before any plan is given for correction. Yes, this is. Thank
Take a deep breath, Shivam. Have some water.
you.
Very, very well covered, but I really don't know how much has sunk in.
So it is because I think
So
what I
stick
was
डायग्राम्स
trying
अगर
to.
यूज करते ना, या तो वीडियोस एटलीस्ट जस्ट डिफरेंट पेशेंट्स के वीडियोस, नॉर्मल गेट वाले, कोई हेमीज,
Yes, ma'am.
because then it
What
becomes more relatable. You know uh, it's not easy for a average orthopedic surgeon to imagine how a passive knee flexion of 15 degrees happens.
Yes, ma'am. Actually, what I was trying to combine both previously the ankle and knee because I think when I was
No,
trying to
which
read
is
for this.
correct. It is very interrelated, and the whole mechanism of the plantar flexion knee extension couple actually really went into detail, especially the vectors, the moments, how the body weight transmits and all. But then when it comes to understanding the other pathologies of individual these things, na, then it becomes very tough for So, I mean, this is just my opinion. You've covered it very well, but you could have presented it in a more simplified manner. Presenting is also the art of teaching.
Yes.
So let the others ask questions if they have any, so that we have a better, clearer understanding as to how much has seeped in and how much needs to be maybe dissected in parts. Chota chota, 2 to 3 slides leke, ek ek do patients bana ke. You all could do this as an exercise amongst yourselves. Sit down with it and try to see, especially the slow motion videos. Bhushan, any comments from you?
No, ma'am, extensively covered. Probably I
Hmm.
would have kind of tried to separate the normal from the
Hmm.
physiological. Probably that would have made it slightly more,
Easier and fluid.
yeah.
EVGS वीडियोस नहीं है क्या तेरे पास?
ड्राइव पे है मैम, वीडियोस तो मिल
नहीं,
जाने।
उसको मीन इसने लिया होता इसमें तो थोड़ा भी नाइस. Any other questions? Mohit, iPhone, which is still not named Nandini, Sanika, and Karthik is can't see him.
Maybe we have to go back and look at this lecture once again for us
Yeah,
to
with
have
the
some
videos. No,
questions.
so say just go back to a couple of first 2 3 slides, Shivam. ये वाला नहीं. I think this is still okay. Then this they have.
Yeah, we were not lost here.
यहाँ भी ठीक ही था, not so bad. From here onwards ना एक एक just photo or just a simple, ये भी ठीक था. This is also okay. This if you could have had some stick diagram or some patient this thing here, especially the limb advancement. This has to be the vectors.
Yes, ma'am. This was, I think,
I think what you all do is go to the physio department in between whenever you all have time and
yes,
practice
ma'am.
this. Just take small slow-mo videos. Nowadays, every phone has it, na?
Yes, ma'am.
Yes, ma'am.
यहाँ से from here onwards, I think just try to understand it better. No, but very good attempt. I'm glad he lasted through the whole thing.
I think I don't know. I think the next presenter is also, because what I had difficulty is, since we are making this separate ankle, knee, hip.
Hmm.
So I went back to Mohit's PPT, and then I had previously seen Sanika's PPT. So I tried to combine so
Hmm.
that maybe there is some ease of understanding.
You know,
But I agree. I think I should have added more
some
videos.
clinical
Well,
pictures. So वो then left to imagination नहीं है. It is more relatable.
yes, ma'am. I agree.
Next वाला कौन ले रहा है?
मेरा है मैम, कार्तिकेय।
अच्छा.
Ma'am, actually we have skipped a week.
हाँ.